So we talk about USCS, we talk about GRD. Maybe I'm very fast because what can I do? I have to finish it in 1 hour. And so many things to tell you about. Patient with cough and no other features of airway disease, the normal spirometry and T2 biomarkers, like I have said, FeNO and eosinophil count. So in these patients, avoid use of ICAs and consider other diagnoses. But there are a group of patients where there is cough with no other symptom of airflow obstruction and raised T2 biomarkers. So in these cases, short trial of ICS for 4 weeks, you can try this budesonide 200 microgram BD to see whether these patients are responding or not. If response is incomplete, consider add-on treatment, like you can use this Montelukast 10 milligram, or you can give a short dose of oral corticosteroid, or you can double the dose of ICS. And when you are giving short course of corticosteroid, the dose is prednisolone 30 milligram for 2 weeks. Another interesting thing I have to tell you, I know that a lot of patients have fear about steroid in our country, but sometimes this drug is really does a wonder and it's life-saving. If you are using once in a while, it's not a major issue. Prednisolone 30 milligram up to 14 days you can use without weaning off. I mean, reducing that 30, 20, 10. That is what the evidence says. But normally when we use beyond 7 days, we like to taper it off. From 8th day, we make it 20 and then 10. But evidence is saying you can use it up to 2 weeks, 30 milligram, and just stop without tapering it. Just for your information. And now it's your decision how you want to stop it, tapering it, or stop it just like that. Cough and other features of airway disease, as I have said, treat according to the guidelines. So eosinophilic airway disease, the eosinophil count is high, so you have to go for T2 markers, you have to go for the history taking, and then you have to go whether ICS will be the right choice. If ICS is partially working, then you have to increase it or adding Montelukast or prednisolone.